Welcome all to this new YouTube video. The topic is Thoracic Cage by me, Dr. Ankit Khandelwal. This is my YouTube channel, Anatomy Explained, and you can also follow me on the various Facebook pages and groups with the name Dr. Ankit Khandelwal Anatomy Discussion. Also, you can follow me on Unacademy, where I teach live. I take Unacademy classes in the platform of NEET PG. Let's come again to the topic of thoracic cage, anatomy of the thoracic cage. So let us see what are the functions of the thoracic cage. The major two functions of thoracic cage is protection of the vital organs. Which vital organs? We all know heart and the lungs, though they are covered themselves by the pericardium and pleura, but still you need a bony cage surrounding them. Second is assist in respiration, because the heart and the pleura and inside with the lungs, these are dynamic organs. They don't remain static like a liver or say a spleen. So they are moving. Respiration. So that respiration, the expansion for inspiration and again going back, elasticity, that is all provided by the thoracic cage. That is the use of thoracic cage, right? So let us see what is the thoracic cage made up of. It's basically made up of a midline sternum. It's an unpaired bone divided into manubrium, a body, and a xiphoid. Then it is made up of 12 pair of ribs, both on right and left side, and each rib will have its own anteriorly lying anterior costal cartilage, which is made up of hyaline, and this is the one which articulates with the sternum. We'll see in the figure. Finally, you have the 12 thoracic vertebrae which are lying behind. So these are the vertebrae which are lying behind. So made up of thoracic cage like this. So this is what it is made up of. Here we are seeing an anterior view of the thoracic cage. What we are seeing? We are seeing a midline sternum divided into manubrium, a body, and a xiphoid. You can see ribs coming on both the sides, and this is the 12 pair of ribs. Now, how many ribs articulate with the sternum? The upper 7, the first 7 ribs, they directly articulate with the sternum via the cartilage. The lower ones, meaning by the 8th, 9th and 10th, this is the 8th, 9th and 10th ribs, they basically does not articulate directly with the sternum. They articulate with this costal margin, this cartilage over here. So they will articulate with the costal margin of the 7th rib. So they form the costal margin over here, right? So this is 7, 8, 9, 10. Now the last two ribs, 11th and 12th rib, they don't come anterior. They are known as floating ribs. So the true ribs are the upper 7 ribs. The lower 5 are basically the false ribs, and in those false, the lower 2 are the floating ribs, right? So this is the ribs, how they are coming, and you can see the shape of the thoracic cage also. It is like a truncated cone with a small superior aperture and a big lower aperture. It is shaped like a truncated cone. Now, is it compressed? Yeah, it is compressed anterior-posteriorly. It is compressed slightly. Why? Because the upper limbs are located over here, and there are various muscles of upper limb which are attached to the thoracic cage. So they actually are pulling the thoracic cage. So it is slightly compressed anterior-posteriorly, and it is more widened transversely, right? That is the thoracic cage from the anterior view. Just to showing you basic outline. So remember how the ribs are articulating, and here is shown a bone, a clavicle with the manubrium, but that is not a part of the thoracic cage. Remember, clavicle is a bone of an upper limb. It falls under the classification of appendicular skeleton. What we are seeing over here is all the parts of axial skeleton. But clavicle, scapula, these are parts of appendicular skeleton. Just showing you over here that how they are attached to the thoracic cage over here. Right, let us move forward. This is again a surface marking thing. Here what we see in a normal patients on day-to-day basis. The suprasternal notch, the jugular notch right over here. This is our jugular notch, right? Below this, few centimeters below it, you feel a transverse ridge. That is a sternal margin, a sternal angle or angle of Louis. As you go below this whole body of sternum, you feel the end of the bony point over here. That is a xiphoid process. Then you see this 8th, 9th and 10th rib with their costal cartilage forming the costal margin. Now remember, if the question comes in the theory, costal margin is formed by, you will say 8th, 9th and 10th costal cartilages. Then they will ask you, is it not contributed by the 11th and 12th? You will say yes, it is contributed. By what? By the anterior end of the 11th and the inferior border of the 12th. So this whole forms a costal margin. Remember that, a very important point. So this is a surface marking over here. Now we'll see what are the various vertebral levels. That is very important table. These are all the bony landmarks with their vertebral levels. Let us see one by one. Jugular notch, we have seen what was that. That was a suprasternal notch right over here. Lying where? If you trace it posteriorly, it lies in the disc between T2, T3, second and third thoracic vertebrae. Then the sternal angle, the angle of Louis, disc between T4, T5 normally. Then the xiphisternum or the xiphoid process, body of T9 body. There is a vertebral level. So these all things are going to be useful when you are seeing in very investigative procedures like a MRI or CT scan. You should be knowing that if you are taking a section at this vertebral level, then what are the things we are going to see anteriorly. Then the tip of 9th costal cartilage, That is actually our transpyloric plane, L1 body. Very, very important plane in abdomen we study. Then the subcostal plane, where the costal margin finishes off below, as around L3. Then you have the root of the spine of scapula, posterior we'll see. Posterior, if you look at the scapula over here, right side is scapula, posterior view. This whole spine, its root over here is lying around the T3 what spine. T3 spine, or it will be around the T upper part of T4 body. Then inferior angle of scapula, again this part of the scapula, around T7 spine. These all things we should know. We'll see them also. But let us move back to this figure just to show you a few things over here. This is T1 vertebrae, that is T2. Look at this, what jugular notch. It is lying T2 T3 junction posteriorly. Then T3 must be over here, T4 must be over here. Sternal margin between T4 T5. Got the point? T5 is over here, 6, 7, 8 and 9 over here. 9 around T, around the xiphoid process. Then you have T9 over here, then you have T10, 11 and 12. You can see the 12th rib over here, T12 over here, and therefore you can see the tip of 9th going around L1. Then subcostal margin going around L3. So these are the things which we should be knowing. This is how the anatomy is going to help you in various investigative procedures once you are going to look at them. Okay, so this was the surface marking over here. Now if you look at the posterior view, what we said about the scapula, that is the root of the spine of the scapula. This is the inferior angle of the scapula. The scapula is a subcutaneous bone, so you can easily feel the spine of scapula. You can feel right now at your own body. And this lies around the T3 spine. So you can these are all the very, very important. This lies around the T7 spine. Very, very important in your clinical examinations, in your investigative procedures. Very important. Okay, so these are the vertebral landmarks. Now let us see a little bit detail of the sternum. Same things over here. How many ribs attached to the sternum? 7. So last one has to be 7th costal cartilage over here. That is the only point. 3 parts vertebrae, body is xiphoid. Remember sternal angle. Very, very important clinically. You have to feel it. The bone is subcutaneous. You can easily feel it in your own or in your patients. Now if you can feel the bone, you can feel the sternal angle, then you should know this for your entire life, everyone. That if you are feeling the sternal angle, the moment you take your finger, you palpate lateral into it, the rib which you feel is always second rib. Because the bone is subcutaneous, easily feel the bone, you can easily feel the angle, you can easily count which rib is this. By this, you can count the below ribs. Anteriorly becomes very easy, else it is not easy. Suppose I ask you to palpate this rib and tell me which rib is this, you'll be confused. It could be 6th or 7th or 8th, I don't know. But if you know the way, then easy, right? So that is a xiphoid process. So this is the whole vertebral column. 3 different angles. What 3 different angles? That is, you are looking at the whole vertebral column anteriorly, laterally and posteriorly. Sir, why anteriorly? Because you are seeing the vertebral bodies. Okay, sir, fine. Why, sir, posteriorly? Because here we can see the spine. And here we are seeing the lateral view. Now, why I am showing you this is because this is a lateral view, that is the anterior, that is the posterior part of this only figure. So what? The thing is, from here to here you have the thoracic vertebrae. They are inclined backwards. The cervical and the lumbar are inclined forwards. So there we call it as a cervical lumbar lordosis. And here we call it as a thoracic vertebrae. It has a kyphosis. Kyphosis, kyphosis. It is inclined backwards. It increases actually our whole thoracic volume. Okay, so that is a thoracic vertebrae. It's normal. It's normal. So we don't see it anteriorly and posteriorly, but if you see it lateral view, you should know what you're looking at. Okay. Now moving from here, a simple vertebrae over here. Now, what is the feature? As we're talking of thoracic cage, I just wanted to mention a little bit of the thoracic vertebrae. The characteristic feature of a thoracic vertebrae, which is not seen in any other vertebrae, and which is seen in all the 12 thoracic vertebrae, is the presence of facets on the body of the thoracic vertebrae. That's all. Every out of 12 out of 12 thoracic vertebrae body will have facets. They can be half, they can be full. That is all a different matter, which is a typical or atypical. But their body will have facets. Typical ones, their transverse process will also have facets. Now they are forming joints. Which joints? See, this is the body, that is the spine. Now, thoracic vertebrae, that has to be anterior, that has to be posterior, right? I'm just trying to show you how the ribs are attached over here. So imagine this is a T5, 5th thoracic vertebrae. The head of the rib articulates over here, 5th rib, and then it will move first backward, And then in the rib, we have a tubercle that will articulate at the transverse process. Then it will curve forward like this, going into the sternum over here. So rib first goes backwards from the head, the neck of the rib, and the neck has a tubercle over here. And then it will rotate around, then it will come forward. And forward you have a cartilage over here that will attach to the sternum. A sternum we already have seen. So these two joints, this is known as a costovertebral joint, that is known as costotransverse joint. All are synovial over here. Lucky part is all are synovial. So why synovial? Because remember the first slide, what was the function of the thoracic cage? Assist in respiration. They are moving. Most of the joints are moving. We come to joints also. Here we come. Here we come to the joints. Now here we are seeing again the anterior view. You'll see the posterior view also. But I wanted to show you various joints over here. I will just name the joints over here that are important. Now see, rib and its cartilage, costochondral joint. Fine. Sternum and the cartilage, sternochondral joint, SCH. Okay. Manubrium and body, manubriosternal joint, that is manubriosternal joint. Fine. Sternochondral done, costochondral done, manubriosternal, that is xiphisternal. This is our intervertebral disc, we are seeing this. Costal margin, all the cartilages, interchondral joint, this is IC, interchondral joints. Posteriorly, there will be costotransverse, costovertebral, that we already have shown you over here, but we'll see in the other view also. So these are all the joints which you are seeing. So sir, what is the importance? Importance is the coming up table over here. What are these varieties of joints? So sternocostal, or you can call it as sternochondral also, right over here, this one. The first one is synchondrosis, the others are all synovial. Only 7 are there. Okay, only 7 ribs. Manubrium, xiphy midline, secondary cartilaginous symphysis joints. Synchondrosis is a primary cartilaginous joint. Then posterior view. This we are seeing the posterior view spines. The ribs are first coming like this, then they will go forward. Okay, the joints formed will be costovertebral, costotransverse. All are synovial, plain variety. Costochondral, interchondral, that also we have seen. Costochondral again primary cartilaginous, but interchondral is plain synovial. So these, you can see most of the joints are plain synovial. These are few joints which are primary cartilaginous, others are all. Why? Because you need to move the thoracic cage, you need to increase the capacity. You need to, because inspiration, when the person is running, more air inspired, you need to increase. Okay, vital capacity, that is all provided by the joints over here. Now another topic over here related to the thoracic cages. What are the structures that are lying superficial to the thoracic cage which are not a part of thorax? But there are a few muscles which are surrounding the thoracic cage outside. We are not going inside. We are not talking of the intercostal muscles. We are talking of the structure which are covering up the thoracic cage. Let us see what are the things which are covering it anteriorly. There are few muscles like P minor, P major, and also if the rectus abdominis, the abdominal wall muscle. They are covering the thoracic cage from anterior. Here is how. The P minor you can see, it's coming from the scapula going to the 3rd, 4th, 5th rib. The P major, the upper 6 ribs over here. P major is the upper limb. P minor is the upper limb muscle. And the rectus abdominis, basically anti-abdominal wall going to the 5th, 6th, 7th rib. So it is these are all covering the thoracic cage anteriorly. Let us see what are the muscles covering it posteriorly. Again, the rhomboids, trapezius, latissimus dorsi, most of them are upper limb muscles. As I told you, that upper limb, both sides, it will pull the thoracic cage. So the thoracic cage is compressed anterior-posteriorly. It is more wide and transversely. Here you see the few muscles. The rhomboids, the levatrus, they are supplied by the brachial plexus nerve. So they are upper limb muscles. Trapezius, that is supplied by spinal accessory nerve. And lower back you have the latissimus dorsi, again brachial plexus nerve to latissimus dorsi. So these are the muscles attached to the thoracic cage, but from the posterior aspect. Again, laterally also you have few muscles like a couple of over here, very important muscles. Serratus anterior, upper limb muscle, and the external oblique, again abdominal wall muscle. Serratus anterior, you can see this is a lateral view. You can see the glenoid fossa over here. The serratus anterior coming from the medial margin of the costal surface of the scapula and going to the upper 8 ribs over here. Lateral. This is the external oblique muscle. Now that is an anterior view, but you can see it is attached over here, the lateral part. In the lower 5 to 6 ribs attach the external oblique muscle of abdominal wall. So these are the few structures which are lying superficial to thoracic cage, and they give the thoracic cage its shape, and they will assist in movement of the thoracic cage and the ribs, obviously, because when the muscles contract, it will produce changes in the ribs, definitely. Okay, so that was all, guys. I hope you enjoyed the small session on thoracic cage. You can follow me on Academy. If you like the channel, please like and subscribe, and that's all. Thank you for your time.